Good morning, everyone. I'll speak about early detection and screening. It's a great pleasure to be here and talk about a subject I love and love to share. So, an overview of the next 20 minutes. I'm going to lay some background for you about your skin and about UV radiation. We'll talk a little bit about melanoma risk factors and what you and your dermatologist can do to protect your skin. So the skin is this amazing organ. It is the largest organ of your body, and it's constantly exposed to change. It covers about 3,000 square inches, or a 6 by 6 foot area. It can weigh between 6 to 12 pounds, and it's an incredibly adaptable and protective barrier. But what is in 1 centimeter cubed of your skin? There could be up to 15 sebaceous or oil glands, a yard of blood vessels, 4 yards of nerves, 100 sweat glands, 300 sensory cells, 300,000 epidermal or skin cells, and about 10 hairs. So in this schematic, you can see all the different things that are going on. It's a really, really busy area. And what you'll notice is there's all this nice collagen and elastin supporting your skin. You'll see that there's hair, there's oil glands, there's sweat ducts, there's those yards of basically all those blood vessels, lymphatics, there's all these sensory nerves and nerve endings. And most important is the business up here. This is the skin. And here, every 3 to 4 weeks, all those skin cells will turn over and over. And along this basal layer, we call it, it's the junction between the epidermis and the supporting dermis, are numerous actively dividing cells. And every 1 out of 4, or 1 out of 10 of these cells is a pigment cell, or a melanocyte, and this is the business of melanoma. And we'll talk a little bit about this, but I want you to see what was going on down here and why all these things are going to come into play in all the various talks you're going to hear today. So what is ultraviolet light radiation? We hear about it all the time. So here is the wavelengths of the various lights. And the important parts that we're going to talk about are the UVA and UVB range. And these two are really, really important, both in photoaging and in skin cancer induction. So UVC was the shortest wavelength, and it's not biologically significant. It's too short. It gets absorbed by the atmosphere. The UVB is really important because it can do sunburns and also various skin cancers. UVA is a little bit longer, and it causes photoaging and also all those photosensitive or photoallergic reactions you might get with medications or chemotherapy, and it also affects the induction of skin cancers. So back to this picture. So what you'll see is that the UVB rays will go all the way down and actually stop right about the basal layer. So here, those light rays can actually damage all those dividing cells and those melanocytes. UVA is a little bit longer. It goes through the epidermis and actually into the upper dermis here, and it actually affects all that nice supportive structure of the collagen and elastin. So that's why as you get older, your skin starts sagging. There's less elasticity. But as you know, as that light came through, it didn't just miss all this. It actually hit the basal layer again and actually hit those melanocytes a second time. What other factors affect UV radiation? High altitude. Patients come back all the time from their hiking vacation or their skiing vacation and are sunburned. It's because of the high altitude and the decreased absorption by the ozone layer of the UV rays. And also low latitudes. Every time we travel to the islands or some kind of nice sunny vacation and you go closer to the equator, that intensity also increases. And summer can have significant seasonal fluctuations, not so much in Texas because we're in the Sun Belt, but if you're in the northern parts of the US, such as Pacific Northwest or the East Coast, there's a significant decrease in UV index over the winter months versus the summer months. What other factors? Reflective surfaces. People forget sometimes they'll be under an umbrella and they got sunburned because it reflected all off the sand around them or the water. Also, when they're skiing, all that bright snow reflects all that sun right back into their face. The only time you really get decreased UV exposure is if there's significant cloud coverage. That means like thunderstorms. People come in all the time from gardening and out, kind of an overcast day, and are sunburned. And underwater means under the water. That means like if you're scuba diving, snorkeling people always get sunburned on their backs. So just be really careful about other surfaces that you might be around. Fitzpatrick skin types. This is a way that a dermatologist kind of organizes their patients. When I see someone come in the room, I kind of think, what kind of skin type does this patient have? Type 1 is someone maybe of Celtic origin, maybe Irish, red hair, freckles easily, light-colored eyes. And they'll tell me they always burn. They never tan. And someone else who has darker skin types will say, oh, always, always tan. I never burn. So there's a whole range, but I don't look at it, it's not an ethnicity, it's actually a specific skin type. So within one ethnic group, say Hispanic, I'll have everyone from type 1 to type 6. And you really have to kind of look at persons on an individual basis and not group them by ethnicity. So type 1 to 3, I think of those patients at increased risk for skin cancer and also for premature aging. Type 4 to 6, they just have more endogenous protection because they have more melanocytes that are actively making melanin or pigment that's somewhat protective. So what are the goals of melanoma surveillance? The first and foremost goal is to detect the melanomas early. Melanomas that are detected early in stage 1 have over a 90 to 95% 5-year survival. Number 2, to minimize the removal of benign lesions. We're not in the business of taking off all your moles. It doesn't help you. It's very disfiguring, it's actually quite stressful, and it doesn't help you because over half of the melanomas arise de novo. That means they don't come from an existing mole, they come from nothing, they just pop up as a melanoma. So if I took off every mole off your body, I wouldn't be helping you in any bit. The third thing is education's probably one of our biggest goals. We educate the patients to protect themselves because we don't see you enough. We might see you once a year, maybe a little bit more frequently if you have a history of melanoma, but you need to recognize your changes in your own skin. So incidence of melanoma is steadily rising, as we all know, and the National Cancer Institute data this year projects 76,000 cases of melanoma, 45,000 in men, and 31,000 cases in the women, and over 9,500 patients will possibly die. What are the risk factors? And many of you may know these personally or have been taught these by your doctor as well, but being fair, having red blonde hair, light-colored eyes, or people who freckle easily, having a family history of melanoma, that means a first-degree relative, a parent, a sibling, or child, having an increased number of nevi, no matter if they all look benign, that actually puts you at increased risk. Having dysplastic nevi means they're atypical, they all look somewhat unusual or not like the one next to them. Large congenital nevi means the nevi that you might be born with or have when you're quite young, but these are usually greater than 20 centimeters, usually in the bathing trunk or truncal distribution. And of course, having excessive sun exposure, usually intense bursts of sun, so sun burning and tanning bed use have been linked with increased risk for melanoma. Personal history is also significant. Patients with a history of melanoma have a 5% increased risk for a second melanoma. Gender and age also come into play. If you're less than 40, women often have it more often than men, and greater than 40, it flips over to men more than women. Immunosuppression also puts you more at risk, so patients who've had an organ transplant, and also some rare genetic diseases such as xeroderma pigmentosum, where there's a defect in a DNA repair. So what are we looking for? As you now know, melanoma is a cancer of those melanocytes, so those 1 in 4 or 1 in 10 cells that are at the basal layer of your epidermis. What we're looking for is an atypical, a new, or a changing nevus or mole. But I'll tell you, melanoma can be anything, and I mean anything. Over all these years, I've seen any new bump or nodule, any change in the color, some redness or some swelling around that mole, new pain, itching, bleeding, tenderness, or suddenly it starts to scale or itch or tingle. These are all things I listen to when patients tell me things because they actually know their body's the best. And many of you have learned this algorithm by now, and something to kind of give you some framework to look at your moles at home. And A is for asymmetry. That means if I put a mirror down the middle of this mole, I want it to look the same on both sides. The border needs to be clean, sharp, even. It shouldn't be scalloped or jagged. And color, patients will often say, well, I have some moles that are tan and some that are brown, some that are pink. And that is your signature. You have multiple types of moles. But within one single mole, we want to see just one color. D is the diameter. It's a general guideline, about 6 millimeters or the top of a pencil eraser. Some of your moles you were born with were larger. That's fine. That's their baseline. But we don't want to see a mole that's been at baseline and start expanding laterally or get wider, because that could be the radial growth phase of a melanoma. And again, this is the same thing, the A, B, C, D, E, but I want to emphasize the E, which was added more recently, in its evolution, any change in a mole. And those are all those things I mentioned already. So these are the 4 most common types of invasive melanoma. The first one here, we'll talk about superficial spreading, and this is about 70% of all melanoma, so this is the majority of them. Here's the nodular melanoma. These are tricky because they grow quickly. Lentigo malignant melanomas occur on areas that have been heavily sun damaged, so often on the head and neck. And acromelanoma is not often talked about, but something we really want to bring up to your attention. It occurs on the palms and the soles, or sometimes in or around the nail beds. So lentigo malignant melanoma, I want to tell you about this one because this is one that is often missed. It's a freckle. It's a changing freckle. So it's something that might have been on your face for a long time, maybe on your arms, and all of a sudden it starts expanding. So in this case, there was this freckle for years and years and years, and all of a sudden it started shifting and going down the eyelid. And also you can obviously see now it's darker and there's a lot of multicoloredness. It's all scalloped. It's not symmetric. And the diameter, I mean, it's basically violated all those rules. But the point was that the freckle had been there for decades, but then started changing. The ugly duckling nevus. This is, majority of patients actually diagnose their own melanomas. And the reason is you look at your skin. You have to look. If you don't look, you're not going to find anything. But the point was this patient had numerous moles, and so it's very, very kind of overwhelming. But the point was most of them were tan to brown, pretty small. This one was probably a little bit larger, but one that had been there for quite some time. But this obviously stuck out. It's scalloped, it's black, it's also brown at one edge. It's very large. So this was the quote, the ugly duckling nevus. So having patients look at their skin, having a friend, a partner, a spouse look at your back and help you with your backside really makes a difference. And everyone should have a good hairdresser. I can't tell you how many melanomas are found by those people on the scalp because no one looks at their scalp. And so they forget about that, and then they get their hair cut regularly or they get their hair styled, and actually they always are the ones who bring those in. So this is the acromelanoma. I just mentioned this for a few minutes. This is the ones that, are often explained as, oh, I dropped something on my nail, or I stubbed my toe or something like that. So, it's sometimes under the nail bed or on the side of the nail, but it can also be on the palms and the soles. And I can tell you, no one looks at the bottoms of their feet. Nobody, except for me. So I look at all your feet, and we look between your toes, and we look under your armpits. We want you to really get examined. But these occur usually later in life. As I mentioned, the palms, the soles, in and around the nails. It only accounts for about 5 to 10% of all the melanomas, but it disproportionately accounts for melanomas in patients with darker skin. So up to 70% of all melanomas in darker pigmented patients, and up to half of the melanomas in Asians specifically. This one is also gets special mention because this gets overlooked and misdiagnosed all the time. It's the amelanotic melanoma. It has no color, so it looks like your skin. It's a skin-colored bump, and it gets confusing because some of your moles may not have much pigment either. But it's going to be new. It might look like a pimple or an ingrown hair, but it doesn't go away. You give that a chance, maybe a few weeks, a month, a couple months. If it doesn't go away, you need to come in and let us take a look at that. So what can you do proactively to protect your skin? This is the key slide, and I actually made a nice handout for you, and it's going to be outside of the desk when you leave. That goes over the next 10 slides. The first thing is to avoid the sun. The second thing is to wear photoprotective clothing. And the third thing is to use sunscreen in that order. Sunscreen is good. It's okay. That's the best rating I'm going to give you. The first thing is to avoid the sun. And if you can't avoid the sun, block the sun from hitting your skin with some kind of significant fabric or hat. So we're going to talk about those in detail. So again, avoiding the sun. I have many people here, especially in this area, who work outdoors. The electricians or they work for the refineries, they're outdoors, but they just need to add some things to what they do outside to protect their skin. But when you're outside for a barbecue or an outdoor activity, try to seek some shade, give your skin a break. The shadow test is that if your shadow is shorter than you are, the sun's probably too strong because it's going to mean that's quite overhead. And another great website or resource to look at is the UV index. People look up where they're going to travel, and they're shocked at how much stronger the UV index is going to be in Colorado or wherever they're traveling, or Florida. So check that website. It's actually quite interesting. The second thing is to wear tightly woven clothing. So if you hold your shirt up to the light and you can see your light through that, it's probably not blocking anything. Darker clothing works better. And what works really well is sun protective clothing. There are several resources that have great sun protective clothing. It's not chemically treated. It's just a very tightly woven nylon. It's very breathable. I've convinced many golfers, fishermen, cyclists to try these clothings, and they have come back, most of them, and have changed some of the things they wear. So try to look at these websites. They offer a lot of different types of clothing for all your activities. Wearing a wide brim hat is better than a baseball cap, but a baseball cap is better than nothing. But for men, I'll tell you, men love wearing baseball caps, but it doesn't protect your most vulnerable areas, which is in and around your ears and the back of your necks and the sides of your face. It doesn't do very much. And sunglasses are really important. They protect the very delicate skin around your eyes. You don't want a skin cancer or anything developing around your eyes. It's a much more involved surgery, and it also delays cataract formation. So here are just two websites that have, FDA-tested material. Slumber clothing is considered a medical device. It truly blocks 95% or more of the UV rays. It's at sunprecautions.com or coolabar.com. You can also buy a treatment called Right Sun Guard. It has a chemical called Tinasorb. You wash your clothes in it, and it actually can possibly last for up to 20 washings thereafter. The third thing and the final thing is to try to use some sunscreen and use a wide spectrum sunscreen with at least an SPF of 30. You don't necessarily need something higher than that. 30 gives you 97% protection. The rest of it is just an arms race. And you need to apply it at least 30 minutes before. Because if you don't, it's not going to stay on, and you're going to be falsely, into some kind of false sense of security. You need to reapply. Reapply frequently, especially if you sweat during exercise or swimming. And don't forget your lips. Lower lips are a notorious area for skin cancers and a lot of precancerous changes. All right, sunscreen real briefly, and there's a handout I'm going to leave, as I mentioned, outside, which is very detailed. That gives you specific sunscreen names. Again, UVA, UVB protection. You're looking for zinc oxide and or titanium dioxide. These are non-chemical sunscreens. They're really important because they won't irritate your skin. They're more photostable. They block a wider spectrum of that UV rays we were discussing. And again, SPF 30 or higher, apply it early and apply it often. So what can dermatologists do to help you detect melanoma? So our experience at MD Anderson is that we perform full body exams, and I mean full body. You take off all your clothes and we look at all your skin. And then we try to teach you about self-exams. That's really important. So you try to do those on a regular basis at home. And I always encourage patients, if they find anything between our visits, to give us a call and come in for that site, and we can look at that site specifically. We utilize mole mapping, and what that is photographs. We take digital photos of all your body, probably about 35 to 45 views. When you come in, we compare each and every mole side by side with these photos. We also use dermoscopy, or what's called epiluminescence microscopy. It's a small device. It has polarized light. It helps us to look at the subsurface pigment patterns. And this slide just reminds you to look at your skin. Again, it's hard, but once patients start doing it, they get used to things, and they start seeing their skin much more comfortably, and they can detect things more easily. Using a handheld mirror is really important. Looking at the bottoms of your feet, the backs of your legs, and your back with a full-length mirror and another handheld mirror. And this is just a slide about mole mapping. Again, patients with hundreds of moles, no one can remember your moles, no one. So if we take these full-body photos, regionally, we will literally go by your upper back, your central upper back, your right upper back, your left, we will go through all the slides and look at all your photos. And I can't tell you how many times that we found a new mole, and there's no way anyone would know it's a new mole. There's too many. Or that it slightly expanded and started getting larger. It's from the mole mapping. And finally, dermoscopy. This has been a really valuable tool that's been kind of incorporated more over the past probably a decade and a half. And basically, it just improves our diagnostic accuracy. It really helps us to become more sensitive and more specific with our evaluations. And this is just one example. The slide's a little blurry, but on the left is the clinical. That means what we see with the naked eye. And on the right, it really opens up the pigment pattern underneath the skin. So in summary, all patients should probably get evaluated by their PCP, their primary care physician, or their dermatologist at least once to assess their risk and how often they'd agree upon to get future exams. Most importantly, you should do your own exams. This is something that is one of the few organ systems you can look at by yourself all the time. So you look at yourself and also kind of become educated about various photoprotective measures. And I'll leave the handouts at the check-in desk on your way out. I printed a lot of them, so feel free to please take one when you leave. And for high-risk patients, routine total body skin exams means they're on a schedule. If you have a history of melanoma in the past, it still requires at least an annual visit. Routine self-skin exams every 1 to 2 months, and a continued photoprotection. And if you're higher risk or have a lot of nevi, possible mole mapping with full-body digital photography and dermoscopic exam of all your nevi. And that's it. Thank you very much.